Hey everybody, Ryan here, and I am thrilled to bring you another episode of Toxicologists vs. the Internet. Today with special guest Dr. Adam Blumenberg. This is a really great episode. Dr. Blumenberg is not just an emergency physician and medical toxicologist, but also has developed a number of free medical or toxicology education software programs and hosts his own podcast about toxicology, Toxic History. We kick the show off talking about some of the initiatives that Adam has brought into the tox community, and then we jump right into cases and questions, covering some unique and interesting topics, like what your differential should be for someone who injected 400 of something into themselves. What kind of things in a hospital garden should make you nervous if you find them in your patient's room, all the different ways illicit drug labs can explode, and a lot more. For those listeners who want to skip the chit-chat and get right to the cases, you can jump to minute 23. For everyone else, I hope you can listen along for some great toxicology conversation. But before we dive in, our standard disclaimers apply. We're going to be answering questions on the internet from people who may be trying to use drugs for the wrong reasons. Anyone using illicit drugs is exposing themselves to risks of potential contaminants, wide dose fluctuations, and toxicities of the drug itself. While this gives us a medium to explore toxicologic concepts, we are not advocating for anyone to use illicit drugs. If you are struggling with substance use, call 1-800-662-4357 to access the SAMHSA free helpline and get the care you deserve. Second, we're going to be talking about real fatalities, and while this allows us to discuss a lot of great learning points, some of these were intentional fatalities. If you or a loved one are struggling with thoughts of suicide, someone's there to listen. 1-800-273-8255 is the National Suicide Prevention Lifeline. Please call. Finally, even though we're going to be discussing medical management, treatment, and diagnosis, this podcast is intended for educational purposes only, and we are not providing medical advice. If you think you're being poisoned or you have a general healthcare question, call your primary care provider or reach out to your local poison center at 1-800-222-1222. Now, without further ado, let's get on with the show. Hey everybody, you are listening to The Poison Lab, a show about poisoning from people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan, and this is a very special episode, another rendition of Toxicologists vs. the Internet. And with me today, I have a guest that I'm really excited to have on the show, Dr. Adam Blumenberg. And Dr. Blumenberg, would you mind introducing yourself?
Sure, and thank you so much, Ryan, for having me. I'm a big fan of the show. I've been listening to it for the last year pretty consistently. It's a favorite of mine. So I'm an ER doctor and a toxicologist, and I'm based in New York City. I work at Columbia University in Upper Manhattan, where I also live. It's a wonderful community. It's a wonderful place to be. See a lot of toxicology both in and out of the hospital. You know, New York City is one of these kind of special places where you have people who kind of come from all over the world, lots of different characters. And we see toxic plants, we see, pharmaceuticals, we see unofficial pharmaceuticals, maybe that's kind of the way to describe it, as well as substances of abuse just kind of out in New York. So it's a pretty unique place.
Yeah. Tox is anywhere there are humans, and you have a high density of humans there. So that makes a lot of sense. Is that a poison museum behind you?
Of course. Yeah. And it's full of goodies. Yeah. Oh, man, where to begin? You'll appreciate this. I got this at a flea market, and it's an old pharmacy stock container.
Oh, nice.
Yeah. And I don't know if you can read it. It says Mithridata.
Oh, yeah. The king of poisons. So hold on. Is that Theriax and Mithridatums that we're talking about here? Yeah.
Yeah.
Mithridates, the poison king who was obsessed with not dying of poison. So he tried to make all these antidotes. And that was the first antidote, really, right? Mithridata? Or was that a Theriac? I don't remember. But
yeah, it was, I think, just a mix of all these random substances that probably didn't help a whole lot.
Oh, yeah. But that was like the birth of the juice cleanse, basically.
Yeah. Yeah, I think that's actually a good tie-in. That kind of is exactly what it sounds like.
I like it.
Just kind of makes you go, you feel different, and you must have been cured.
Right? Exactly. Well, that's wonderful. Yeah, you can't be a toxicologist without a museum. Mine is upstairs in my living room. but
Nice.
I've got some fun ones there. Mad Honey,
Oh
a
yeah.
couple empty vials of Thai green pit viper snake antivenom that we used on a
Oh,
patient.
that's cool.
I
That's
try
cool.
to hold on to any antidote that I get to use at bedside. I try to keep.
Yeah.
Got a
And
broken
especially the cool one.
physostigmine vial in there. So
Oh yeah. Yeah. They're not making that anymore. Probably anytime soon, huh?
probably ever.
Oh.
Acorn, the
Hmm.
manufacturer, just announced that they're closing their plant.
Wow.
There's no longer any manufacturers of physostigmine. I don't know if somebody else can pick up their recipe, but it's at this point it's going to be gone because they're the only place that made it in the US.
That's really too bad. I mean, it's just not going to be available to all these patients who need it, and we're going to have generations of trainees who have no experience with it.
Right. It's a bummer.
Yeah.
I'm hoping somebody can pick it up. I also think Acorn made calcium disodium acetate.
Mm,
So I'm a little nervous about that too, because that's been gone for a long time.
yeah.
Okay. So, for the listeners, Dr. Blumenberg is also involved in a number of really fascinating and great educational toxicology activities. Not why I invited him on the show. I actually have an anecdote for that I'd like to share in a minute. But I really want to talk about the great stuff that you're also doing. So, first, you have your own podcast, Toxic History. Would you mind commenting on what that is and where you can hear it?
That's right. Yeah. Thanks. Toxic History is a podcast and a YouTube series about events from the history of poison. And I host and moderate it and invite different toxicologists and physicians and pharmacists to speak on the podcast about just events of poisoning history. So, for example, the first episode is about the Oregon State Hospital poisoning disaster. There's an episode devoted to the history of toxicology in classical music. There's another episode about the Iraqi grain poisoning disaster. And so we have these specialists and experts who are telling these narrative medicine stories, but from the point of view of toxicology.
I've listened and I really enjoyed it. The last one I listened to was about an expedition leading to, I believe it was the ingestion of polar bear livers, which then led to, I don't know if it was polar bears, but then led to hypervitaminosis A and all sorts of problems from that. I remember that one being really interesting.
That's an awesome episode. Yeah. And I'm so sorry to say, I think it was actually dog livers,
Oh
which
no,
no, which I'm a big dog fan, so it's a
I know.
heartbreaking one to hear. Yeah.
Yes. And then a number of other really cool educational things that you have. So oh, I'm going to butcher this. Med Sim Simulator? Is that the
MedSim Studio.
MedSim Studio? So this is for the listeners. I have used this and I really loved it. This is a virtual program, and this is my interpretation of it, that allows you to basically do a lot of simulated cases. You can simulate vital signs imaging that would occur if you're doing like a medical sim case for someone. So the other day, I ended up having a really fun experience where I pushed bicarb at the bedside for a patient with a wide QRS. It's actually from hyperkalemia, but it narrowed, and it was really fun to see the end tidal CO2 rise and see the narrowing of the QRS. And I was like, I really love sharing those moments with learners. And I was like, I don't have this on video. I can't videotape the patient. So how do I do this? I actually used your MedSim to recreate that moment where the QRS narrows and the end tidal CO2 is going up, because it demonstrates so many cool aspects of physiology, bicarb turning into carbon dioxide, measuring it. And I thought it was super useful. So I really encourage people to go check that out. You can download it and it's free. I
Yeah, completely
didn't pay
free.
for it. Anything else you want to share about that program?
Sure. And I'm so glad to hear that you're using it to teach other clinicians and to kind of recreate these exciting cases. So where I work, I'm a simulation educator. I teach through sim several times per month. Doctors, nurses, pharmacists, residents, students, everyone who joins. Mostly what's called in situ sim, which is in the clinical space. So we actually run through these cases inside our resuscitation bay of our ED. And so I developed this software, MedSim Studio, kind of out of a need to have a mobile way to display all this data, vital signs, ultrasounds, EKGs, chest X-rays, all this stuff that you need to teach your learners. And I wanted it in such a way that you could very quickly display that information and then get back to teaching. So I'm so glad to hear that you're using it because that's what it's there for.
Yeah.
And like you said, it's totally free. It's not a commercial product or anything.
That's really wonderful. I'm curious, did you code this thing yourself? How did you develop this?
I did, yeah. So I learned to code basic stuff in high school. I took a year-long C++ course, and I really enjoyed it. It was very math based, um, but I didn't really learn how to do anything with graphics or how to make it look nice or anything like that. And then through college, med school, and through residency, I learned a bit more detailed, basically through YouTube videos. There's all these incredible teaching videos that are just available for free on YouTube, and learned from these internet instructors a bit more advanced techniques about how to make software. And out of that came this particular software, MedSim Studio, and one other piece of software which I hate to self plug, but it's also free, not commercial. Yeah, it's called Tox Runner, which is a question bank app that's available for toxicologists.
Where does runner come from?
That's a good question. At this point I don't even remember. I think it was meant that it runs questions, something like that. But
That's awesome. Well, there's a lot of information to know in toxicology, so anything that can help increase the retention there, that's wonderful. I got to pick your brain sometime. During COVID in March, um, I was like at home for 10 days because everything was shut down, and I happened to have some time off from the ER, and I kind of in a spurt of, I don't know what it was, inspiration or like unipolar hypomania, I don't know what, but I learned to code HTML. I coded a shock video game, which I have. It's free. It's on the website for the podcast. But where
Oh,
you,
I checked it out. I like it. Yeah, and it kind of it responds to all the, like you put in the different pressors, and
yeah,
so it's a kind of a calculator too, kind of a physiologic simulator. That thing was cool.
it's basically a calculator. Yeah, I mean, there's a digital cardiovascular system with a couple of variables that are interplaying on each other, and then the vasopressors change those variables, which then change the other. So you can watch. You basically, have to identify what shock it is. You get to know their CVP, their cardiac output, their stroke volume, and you can measure their systemic vascular resistance, which is fun. And then you see the effects all the pressors have on it. And I would love. It's just the problem is it's so ugly. I need to figure out how to make it not so ugly. So one day maybe I can pick your brain on that because that'd be really cool. But
Sure.
obviously you're involved in a lot of really fun things and putting out a lot of useful tools for the tox community. So thanks for that. But that is not why I invited you on the show. I I knew I needed to invite you on the show after the last episode of Toxicologists versus the Internet with Dr. Emily Kiernan. On one of our questions, we were talking about drinking bong water that had been used with methamphetamine. And we had a fun little discussion about, okay, well, methamphetamine is not that water soluble, but the salt, methamphetamine freebase is not that water soluble, but the actual salt, methamphetamine hydrochloride, which most people are actually using, is pretty water soluble. So you can supersaturate those solutions, all those things. And then I got an email from you, and it was one of the funniest emails I've ever read in my life. In my life,
Good.
largely because I could tell you're kind of an experimenter. You like to solve things for yourself, and I think that's wonderful. But Dr. Blumenberg brought up the fact that other drugs have freebase and salt forms, and mentioned lidocaine is one of those drugs. So lidocaine hydrochloride is what you're usually going to find in your vial of lidocaine 1% in the ED. But if you actually add some base to that and raise the pH of your solution, you can actually turn lidocaine back into the freebase form of just pure lidocaine, and then you can evaporate off the solvent and have little lidocaine crystals. And this email was complete with a picture of your recently crystallized lidocaine that you had managed to create. And I was blown away. I thought it was really fun. All with products that you found right in the emergency department, I believe. I'm
Yep.
not going to
Yep.
say that you took them home. I don't know, but it was a.
No comment on that, but you can
Yeah.
see my stove in the background of the picture. I don't know how that happened. Yeah.
Uh, and I really appreciate it. And then I believe you also had a picture of some bupropion. All right, people are going to get at me because I always say bupropion. It's bupropion that you, the extended release and sustained release that you had filed down to examine the different delayed release mechanisms. And I thought that was a is this accurate? Am I telling this appropriately?
Yeah, no, that's exactly right. I was just kind of curious about kind of what's in there because I think a lot of us are familiar with how these modified release preparations, there's a lot of just engineering, not even chemical engineering, but physical engineering that goes into these capsules. And I was just curious how they're built. So I kind of took some fine grit sandpaper and filed them down until they were in the cross section form and took high resolution close up photos and obviously discarded the powder, but looked very closely at those kind of those pills in half profile to see what was in there. And there's a kind of a famous case report out there that has photos of ghost capsules let's say on the other end after whole barrel irrigation of bupropion XL, and they kind of look like a hollowed out M&M. There's that just kind of plastic cap, and you can really see that little ring of plastic material encasing the actual medicine. So that was kind of cool to see.
It is really. I mean, some of those methods they use to create delayed release profiles are really fascinating and
Yeah.
sophisticated. I talk a lot. I pick the brains of our drug delivery kind of PhDs at the pharmacy school a lot, and I love hearing what they have to say about, targeting, delivering medicine to different parts of the body, all sorts of really interesting things.
Oh, I'd love to hear a little bit of a summary or takeaway from that because that sounds really interesting.
Oh, just trying to tag parts of the body and then create the drug with almost a immunoglobulin
Hmm.
or an antigen portion of the body that it can kind of seek out and attach to. I mean, that's a very basic,
No, that's
but
such a cool idea.
one
Yeah.
day, yeah, you don't always have to give drugs to all organs, right? So maybe in the future that'll change.
Yeah.
Well, I really appreciate you joining the show. And after I saw your experiments, and actually that prompted a fun discussion. We were talking about the efficacy of lidocaine, yeah, whether it was more effective ionized or unionized, largely, right? And you actually wrote a paper.
It kind of came from this kind of this discussion we were having about exactly this, the free base and the salt form of lidocaine. And I just, you know how sometimes these kind of factoids stick in your mind from years and years ago. One of the factoids that had stuck in my mind was that lidocaine and most local anesthetics don't work very effectively in tissue where the local pH is low. So, for example, infected tissue, you're going to have some anesthetic effects if you're numbing up an abscess locally. But as a general rule, if you can do a more proximal nerve block or a ring block, that might be a little better. And you'll get some anesthesia if you numb it up directly, but it takes longer to kick in. I also remember learning that if someone swallows lidocaine because the pH of the stomach is so low, it's unlikely to kind of soothe any kind of gastric ulcer pain, things like that. And one of the ways that some clinicians might get around this is to mix it with a little bit of sodium bicarbonate before injection. Personally, I've never done that, but I know some people, some docs have done that.
Yeah.
Um, and the presumed reason this happens is that the target of the lidocaine, the sodium channel, the place where the lidocaine molecule actually binds to is on the intracellular surface. So it actually has to cross through the lipid bilayer and get inside the cytoplasm and bind to the channel from inside the cell. And because the lipid bilayer is lipid, if it's in its salt form, it's not going to be able to dissolve in the lipid bilayer very effectively. It has to be in its free base form.
Right.
And so that was kind of what prompted this kind of just train of thought. How does the lidocaine actually get to its target site, and how does that relate to pH?
Then we got into the discussion, I believe, of the receptor dissociation constant. So there's that side of it where you have to be free base. The more lipophilic you are, the more likely you are to access the receptor. But this is one of the old school teachings of lidocaine is a preferential antiarrhythmic in ischemia,
Mhm.
because if you give lidocaine, yes, the pH is going to be lower in the area of ischemia. So you're actually going to have more protonated lidocaine, which is not going to get into that lipophilic cell layer and access the receptor. But the ones that do get into the receptor, they will actually then get protonated at the receptor site, and their dissociation constant back into the lipophilic cell layer is lower then. So it's going to actually stay on the receptor site longer. is the theory behind that. And that's kind of been shown in some rabbit heart tissues. So maybe it makes it, to increase the pH, a better local anesthetic because you get more rapid anesthesia, but lower pH, better antiarrhythmic because you get a more long-lasting. Anyways, that was a fun discussion that we had, and I'm glad we could still remember it. Yeah. There's a lot to remember. You say, okay, does it get protonated or unprotonated? Yeah, but it's fun physiologic principles to think about. Mm-hmm. Well, I think that's enough blabbering from us about fun things. Let's talk about other fun things. Well, and first, just real quick, for anyone out there listening who wants to follow in the steps of Dr. Blumenberg, would you mind just giving us a quick what brought you into toxicology in the first place?
Yeah, I'd be happy to. So I've always loved basic science, chemistry, clinical chemistry, how the body works. And I've also always loved history and culture and society and how people work. And toxicology is just this amazing intersection within medicine between basic science and human behavior. The strange things that we do as people, the strange things we do as societies, disasters, as well as just more kind of individual behaviors that kind of really come down to what is biochemically going on in this person's body. And that's something that's been kind of endlessly fascinating to me because it's so detailed and so specific as well as so broad.
It's such an interesting intersection. And there's a lot going on right now. And there's always a lot going on, but it seems like humans need to be present sometimes to cause some toxic entities. What we had in the last month, there was a nitric acid spill in Arizona, I believe. Mm-hmm. We have vinyl chloride. Did you happen to see the movie White Noise on Netflix?
No, I haven't. What's it about?
It's a very interesting film, but it basically centers around a train accident with this large looming airborne toxic event. And then all the people are leaving, and it's kind of a satire. But then here we have in Ohio, I mean, you could look at a picture of the movie and a picture of Ohio, East Palestine, and it looks identical. It's wild. But basically, yeah, in Ohio, we have this vinyl chloride spill. And oh, man, I feel so bad for people who had to evacuate, but safety first. And then there was a metal factory explosion in Ohio. So unfortunately, yeah, we have a lot of advanced technologies, but they come with risks, and we are struggling to contain them sometimes. But yeah, humans, society, we create toxicity as well, and as well as experience. So that's wonderful. Well, I appreciate you joining us today, and I'm excited to get to talk with you about some fun other topics. Now that I've seen how your mind works already, and it's very impressive. So I think we're going to dive in to our cases right away. So for the listeners, this is where we go through cases of fatal or potentially non-fatal poisoning, sourced usually from the America's Poison Center's annual report or case report, anything you find that you think is interesting to bring up. And these were real cases of real fatalities or real serious toxicities that occur. We don't want to make light of that, but we do want people to be able to understand what people who manage poisonings think about when they hear about a specific presentation. So we want to make sure people can hopefully be better able to identify some of these fatal poisonings and intervene faster to prevent that. So we're going to be talking about a couple of cases, and we're going to read the case without giving away sort of what the toxin is. We're going to read their vitals, their labs, all the things that we might talk about. We won't give away any antidotes. And the other is going to do their best to talk about what it's making them think of and hopefully land on the correct poison. But sometimes you really can't do that till autopsy. So you just never know. And with that, hopefully people learn some fun stuff. So would you like me to read you a case first, or would you like to read the case to me first?
Why don't you read a case first?
Okay, I will read you a case. So I think we got some fun ones. This is a very short one. Probably something you've done in the sim lab, to be honest. So we'll kick it off with this. So a 4-year-old female presents to the emergency department complaining of abdominal pain and vomiting, kind of not able to take PO. In the ED, an abdominal ultrasound ruled out appendicitis, and she tolerated sips of water and was discharged home. 15 days later, she was transported to a regional trauma center in cardiac arrest. They were doing resuscitation. They got labs back that showed an H&H of very low, like 4. Then there was some stuff done that I can't share. There was imaging. She was taken to the OR, given blood products for a large presumed bleed, and she arrested in the operating room and died.
Sad case.
It is.
Yeah.
Really sad.
So I think there are some hints as to what's going on. We can at least kind of come up with a differential. So just to kind of re-summarize, we have a child, a 4-year-old, who presents with abdominal pain and vomiting. There's a lot of things that can cause that. And then is presumably well enough to be discharged from the emergency department, followed by a 14-day essentially gap. Maybe is sick during this time, maybe is not. But certainly by the end of this 14-day period becomes critically ill with a severe anemia, enough so that she does not survive. So hearing a history like this, I'm thinking about toxins that can produce either hemolysis or bleeding, as well as over the course of this period of time, maybe a little bit of decreased erythropoiesis, although really it's not enough time, 14 days, to cause a meaningful anemia from that mechanism. So unless, of course, this was a longer period of toxicity than the 14 days. So things that I would be thinking about to start would be caustics. I'm thinking about lye, muriatic acid, which is just hydrochloric acid, which can cause abdominal pain and vomiting, as well as some degree of destruction to the GI tract, which could cause bleeding over the next few days if there was an initial recovery. I'm also going to be thinking about certain heavy metals, specifically iron, which can cause these types of symptoms, can cause bleeding, can cause a period of kind of very serious illness, followed by partial recovery, followed by getting sick again. I'm thinking about lead exposure, as well as both kind of acute and chronic. And then also thinking about, sadly, child abuse. So kind of repeated dosing of some other type of pharmaceutical that could cause the patient to become initially sick and then essentially poison the child again later. And that could be just about anything that could cause a shock state or bleeding.
Excellent. Dude, I'm trying to figure out how I could share more of this information without giving it away. But yeah, I mean, I think those are great. Certainly things that inhibit like hematopoiesis, certainly things we see, nausea, vomiting, abdominal pain in a 14-day tragic case is colchicine always jumps to mind too, but antimitotics. But it's really hard because we have 14 days between presentation and death. We have no idea what happened in between. I would say most likely what would happen here is immediately after going home, progressively worse abdominal pain, decreased PO progressing. I'm actually very surprised to hear this took 14 days to represent. I could give you a hint. Mm-hmm. An abdominal x-ray in the emergency department would have immediately diagnosed this.
Mm. I would also be thinking about, with something like that, would be a button battery, as well as, just sharp objects, but a button battery is something I'm really thinking about.
That would be correct. So this is a tragic case of a lithium-ion button battery. Mm. So this is what I couldn't share with you. At the regional trauma center, a lithium button battery was found lodged in the esophagus that had eroded through the esophagus into the aorta. This is one that just always blows my mind. These little button batteries, and it's all about size and age. So every time I get a call from one of these, I really get nervous because of how much damage they can cause. And there's great button battery triage guidelines, I think put out by National Capital Poison Center. But it really has to do with the age of the person, whether or not the size of the battery, the voltage of the battery. And once you can confirm it's past the esophagus, it's usually not so much of an issue. But if that is caught in the esophagus, and you can usually see it on x-ray, you need to get it out really right away because it can cause burns within 2 hours. So I don't know. Did you ever do a hot dog experiment with the lithium ion batteries?
Yeah, and there's a whole bunch of these YouTube videos of those, and it's something I've kind of shared with learners, students, and residents just to show how destructive these things can be, how quickly.
Yeah, it's just wild. So anyone at home, if you want to see the damage a lithium ion battery can cause, just cut a slit in a hot dog and leave the battery in there. It could take a little while depending on your voltage, but you should see a hot dog starting to cook. We actually recently got one of my colleagues, Matt Stanton, who's been on the show before. He got some pig esophaguses from a butcher, and we actually did the experiment with those, and it's pretty wild. Let's say you have someone who adjusts the battery. Well, I just need to rush you to the ER and make sure it gets out. But I can't really do much in the interim. Until 2018, there was a really good paper that, unfortunately for these pigs, it was really sad. They basically lodged button batteries in their esophagus and fed them either saline or honey every 15 minutes, and then let them for an hour, and then let them kind of walk around, and then sacrifice the pigs and pulled out the esophagus, looked at the damage. And the ones who had honey really had decreased burn. I think it was both surface area and depth. So that's at least one thing we have now, and that's something we're kind of adopting, and it's now in the National Capital Poison Center guideline, I think, too, to give honey 10 mLs every 10 minutes if they're greater than 12 months. It's at least something you can do to prevent further damage, which sounds like not that exciting, but it is. It's something you can do. So I don't know.
No, I think that's super important. So where I trained, my fellowship training was in Oregon, and we were the poison center for the state of Oregon, which is a fairly large and relatively sparsely populated state, especially to compared to New York or the dense northeast cities. And we also covered the entire state of Alaska. And one of the issues that we would come up would be with the issue of medevac. So if someone needed medical care to actually get them to a tertiary hospital, where might you have a pediatric gastroenterologist? It might be a 6 hour flight away. And so anything you could do to potentially temporize that or buy a little more time can make a huge difference potentially.
Yeah. Oh, I can't imagine in Alaska. You got a ticking time bomb and care is many hours away.
Hmm.
Well, I just wanted to bring that one up because I think people sometimes don't realize how dangerous those can be, and want to make sure that that gets out there. Certainly, I think the public is not so aware. So hopefully they can spread the word for us. But all right, you got one for me. I'm looking forward to getting stumped today.
Sure. Okay. So I'll dive into it. So, a 57-year-old man with Asperger's syndrome presented complaining of diffuse pain and generalized malaise. Mentally, he was impaired with disjointed thoughts, labile mood, and disorganized slurred speech. He denied taking any over the counter or herbal medications, and his history was otherwise uninformative. A screening basic metabolic panel returned with a chloride level greater than 175 milliequivalents per liter, which is above the threshold of detection, and an anion gap of negative 55 milliequivalents per liter. To rule out laboratory error, a repeat BMP was performed and confirmed the initial value.
Mm. All right. You're giving me easy ones. You just don't want to stump me. I appreciate it.
Yeah. Good
Well,
topic for discussion.
it is. So it could actually be potentially two things. I believe this is bromism. Bromide is in the same column of the periodic table as chloride. And people who take bromide, which right now the most common source would be dextromethorphan hydrobromide, could also be diquat dibromide, but I really doubt they're having fun with diquat. Or you can actually just buy bromide salt still on the internet, and some people do that. It used to be used frequently for seizures and alcohol withdrawal. They used to use it all the time. I've actually had some cases of people who are trying to detox from alcohol, and they will buy bromide salts online and take them. And then they come in with a negative anion gap and a chloride of 175. One other thing to consider here. So I'm looking based off of the description, labile mood, disorganized and slurred speech. It seems like there's some neuro effects going on here, lacking. Certainly not an anion gap, but just this makes me think of one thing. Salicylates, depending on the actual lab that you're using, some of them will actually measure salicylate ion as chloride. I believe it's a specific spectrophotometric lab. I can't recall, but there are at least two case reports I know of a patient coming in with a very serious salicylate level, no anion gap, and actually a very elevated chloride because the lab was misreading the salicylate as chloride. Then when you actually check the salicylate, it's quite high. But given the discussion here, I'm leaning more towards bromism. Um, and what was their QTC? Do we have that? And maybe that'll lean me in on whether this was dexamethorphan or
We don't have an EKG available, but if it were available, I think it would be normal.
okay. All right. Well then, I'm gonna go with bromide salts that he bought on the internet.
Yes, it's always the internet. And so you got it. This is bromide salt. And what's kind of interesting, and this again ties into just this kind of human beings are interesting people. And I am happy to say that this patient recovered completely and did well. He was buying salt from the Dead Sea. And
Wow.
I didn't know this until I read this case report, but the Dead Sea contains a very high concentration of bromide. And so the precipitated salt, uh, if you ingest that in high doses or at high frequency, it can cause bromism. And so that's how this patient got sick.
That is so fascinating. So are there people out there who just like strain the Dead Sea and or boil off the water and just have a good time with Dead Sea salt?
Yeah, so it's sold commercially. It's probably not meant to be ingested. I hope it's not marketed to be ingested. But yeah, you can buy Dead Sea salt and you can use it kind of like Epsom salts. You can soak in it, make a bath out of it.
Yeah.
Some believe it has healing properties, maybe mystical healing properties. It's
Now I know why.
yeah, reputed to be good for the skin. Um, but of course, if someone's ingesting it, that's a completely different story.
Yes. All right. Well, no more Himalayan pink sea salt. I'm going Dead Sea.
Go all the way with it.
That's awesome. Well, that's so interesting. Yeah, we've had a couple cases that have needed dialysis to clear because
Mhm,
they've been so obtunded. And then you have the whole concept of bromide withdrawal. So it's bromide, right? In your neurons,
mhm.
the GABA channel or the GABA receptor basically is a ligand gated ion channel. It means you need a drug, the GABA A channel. You need a drug to open it up. And then once it opens up, chloride rushes into the cell and makes the cell more negative, less likely to depolarize. And thus you can get, a negative excitatory effect. This is what alcohol does. This is what barbiturates, benzodiazepines, all sorts of things. They make the cells more negative, less likely to fire. Bromide acts like a chloride ion and can actually get into the cell and create this more negativity in the cell and reduce synaptic firing. So it really has the same effect as a GABA agonist. I wonder if it affects GABA receptors. I assume it gets through the GABA channel, but kind of the withdrawal is another thought to consider.
Oh,
Um,
that's a really cool thought. I never even thought about that.
yeah,
Something we see so rarely,
right.
but you know, it could happen.
I think in the 50s it was more common. Another consideration for a high chloride could have been iodide.
Yeah.
Iodide itself, not
Yep.
iodine. And I don't know where you're going to really get that potassium iodide, but if you take
I
enough
guess
of that,
there. SSKI. I wonder if people are stockpiling it and just with what's happening in the past
right,
year or so.
right, yeah. Anyways, really great case. Wonderful. All right, I got another one for you.
Cool.
So unfortunately, it's tough when there's no exposure history, right? Like the button battery, we know as soon as like, oh, they're playing with the remote. Well, okay, I know exactly what to do. In the rare case where they show up and there's no exposure history, it's tough to figure out.
Yeah.
This one would also be tough to know without an exposure history. So I'm going to give you some. A 37-year-old male injected the extraction from 400 somethings mixed with acetone into his left bicep muscle in a suicide attempt. The next morning, he developed respiratory difficulties, requested 911 medical assistance, and was brought to the emergency department. There's a history of IV drug use, depression, prior suicide attempts, apparently greater than 10. His home medications include methadone, bupropion, hydroxyzine, mirtazapine, lamictal, and albuterol. On physical exam, the injection site was bruised, painful, and erythematous. His whole torso was erythematous, and he was hypoxic and complained of chest pain. He was alert and oriented. His oxygen saturation was actually low, about 80% on room air placed on oxygen. His ECG was unremarkable. In lab findings, his AST and ALT were slightly elevated. Nothing impressive other than an AST-ALT elevation. On the clinical course, so the patient presented to the emergency department with increased oxygen requirements. They threw him on oxygen. He sat in the hospital for about 3 days with twitching and flank pain. On day 4, he was still alert and oriented, but he wasn't really eating or drinking. He started to develop coagulopathy as well as a platelet of 53. They initiated plasmapheresis for him. About 6 days in, his blood pressure decreased. He was having liver, kidney failure, as well as pulmonary failure, it appeared. He was intubated, started on norepi, CRT, paralyzed and sedated with midazolam and hydromorphone, and then still was on multi-system organ failure. And they eventually withdrew care on hospital day 13. Whew. From this person who ground up 400 somethings and injected them into his bicep.
That's a very unusual case.
It is, and just to clarify, I would not get this without knowing exactly what they had taken.
Sure.
But I think the clue is there's 400 of something.
Yeah. Well, let's play it out. Let's talk about some possibilities. So I think the 400 of something is a big clue. So things I'm thinking about. So we have one, parenteral exposure, which is a little different than a lot of our other toxic exposures, which tend to be ingestions or dermal exposures. It's presumably not a pharmaceutical. It's something that can dissolve in acetone, and it's something that over the next few days leads to multi-organ dysfunction. So starting with the pneumonitis, that's kind of could be anything that is injected into the vascular system and kind of disrupts the lungs. That's going to be the first stop. And then over the next couple of days, really destroys or damages the liver, platelets, and coagulopathy. So short answer is I don't really know. I think there are many things that could do this that I would never think to inject into the bloodstream directly. Anything from seeds, things like rice, plant material, anything like that could contain a lot of particulates and things like that. It could be something that is a plastic that is soluble in acetone, but then when you mix it with an aqueous solution like blood, it starts to form little microprecipitates and forms little microemboli all over the body. It could be something else like a fat embolism. This could be something that contains 400 packets of butter or something, and then this is a completely external fat embolism, which gives you low platelets and pneumonitis. So I don't think I know the answer to this one, but I'd love to hear what happened here.
That's a great differential, and I think you inject something in your body, you can get excipients that cause emboli in the lungs that are going to cause there used to be something called cotton fever, where people would strain their heroin with cotton and then get febrile and have pulmonary issues from the cotton they were injecting. So obviously this is one problem with injecting tablets too, right? You're going to get all these excipients that are going to go to the lungs, right? All roads lead to the lungs at some point, and they can get caught there and cause problems. So this was somebody who had attempted suicide greater than 10 times. I guess I'd give you a hint.
Sure.
If I give you the real hint, like you would, so for obviously it seems like it's a multi-system effect, right? So it seems to affect everything. It's so hard to do this one without saying what will give it away. You probably researched online because it's a well-known poison that's been used in a lot of poisonings, some involving Russian dissidents.
Huh.
It is a plant material.
Interesting. Okay. So it's interesting you say that. Now, let me ask you for
Yeah.
one question. Is this plant material ever found in the tip of an umbrella? Yeah.
It has been distilled down into the tip of an umbrella before.
Okay. Um, Interesting. So, unfortunately, a creative approach to a suicide attempt for this individual who was able to complete this suicide attempt. So, what you're describing is ricin, and that's coming from castor beans. And I think the amount of ricin in 400 castor beans is certainly will do the trick if it was appropriately extracted.
That would be correct.
So you could see kind of some of those initial effects of just kind of particulate matter being injected, followed by essentially RNA inhibition over the next few days.
You hear about it every year. I see reports about it every year. I think it suffers from the fact that it's such a well-known poison kind of in the media. Wikipedia has a whole list of ricin-related events that have occurred, but they have, Georgy Markov
Yeah.
in 1978. He was a writer who I believe, I don't know if they figured out exactly who, but I think that is pinned on Russia. I think he was writing some things that were not so great about their regime. And
Toxo here, to correct Ryan's naturally failing human brain. Markov was critical on Bulgaria, not Russia. However, the Soviet KGB was suspected to be involved in the assassination.
Somebody came in with an umbrella that had a pellet in the tip of it and either shot him or poked him in the leg with the umbrella. And then a few days later, he wound up hospitalized, multi-system organ failure, and died because there was a poison ricin pellet in the umbrella. It's also used in Breaking Bad. Walter White uses it he extracts from the castor bean ricin to try to kill Tuco Salamanca when he's trapped in like episode 2 or something. And then he also uses it again in the future to poison, I think, some family members. I can't remember the details, but it's well known as a poison. And because of that, people tend to ingest it, unfortunately, in self-harm. So, but there is a slight benefit here. So ricin, when taken orally in seed form, people, if they are trying to harm themselves, they just take a few seeds. Luckily, the seed tends to protect absorption of ricin, so you don't see much if they just swallow it. So in those cases, we usually see pretty minimal symptoms, which is nice. So they know it's bad and scary and they take it, but luckily, if they're not chewing the seed or grinding it up, they're not likely to absorb a lot. But then on the other side of the spectrum, people who know that ricin, has these effects, they will grind it up and do things like this, where they will inject it into their bicep. So I've had a number of cases of ricin, and it's interesting. It's usually a couple of seeds that are ground up, and it just causes diffuse diarrhea for like 8 hours because it destroys the GI cells, but it's not well absorbed orally. I've also had cases where people are using it for weight loss because of that. So they'll make castor bean smoothies and ingest that so that they can lose a lot of water weight via the GI tract, which I don't know if is a great idea. And for the listeners, ricin is really an interesting poison. I wanted to just walk through real quick its mechanism because I think it's so fascinating. So ricin inhibits protein synthesis. And so when you make a protein, right, you have your DNA, which is like the code, and then you take a copy of that code that's called messenger RNA, and that RNA leaves the nucleus and goes out and gets grabbed by something called a ribosome. And the ribosome is this really cool cellular machine. It's both protein, which is made of amino acid, but it's also composed of nucleotides, which are the things that make up DNA and RNA. So it's part protein, part nucleotide, full machine. And ribosomes grab that messenger RNA and they read the code. It's like, okay, if you have 3 base pairs, it's like AGG. It's like, okay, I need this amino acid and I'll add it on. So then tRNA goes and grabs the amino acid and adds it. But then it has to move to the next set of base pairs. So the ribosome has to move along the RNA, the mRNA. And the way it does that, it's an energy process, right? You need to have energy to move. So it does that by cleaving it does that using GTP, not ATP, but GTP, guanine triphosphate, I believe is that what that stands for. And it cleaves a phosphate using something called the tyrosine ricin loop, which is this big loop of RNA that's preserved across almost all living things. So every living thing that produces protein seems to have this. It's called the SRL, tyrosine ricin loop, that is responsible for generating the energy that helps the ribosome move along the mRNA. And this is smart of the castor bean, which doesn't want to be eaten by anything, that it generates a poison that targets something that's preserved among all living organisms. But what ricin does is basically there's this A chain on the ricin. It's a big protein, and there's this chain on it that cleaves an adenine molecule out of this RNA loop. And apparently this was where it got too complicated for me. Something about pi bonds. But when the adenine gets cleaved, the entire tyrosine ricin loop collapses and the ribosome can no longer move forward on mRNA. So it halts transcription of proteins. Or sorry, not transcription. It halts protein synthesis at translation. The ribosome can't move, it's paralyzed. And then all of a sudden you got no proteins, your cells die. But all of your cells need to produce proteins, right? So this affects basically every organ system, although you don't see a lot of neurotoxicity until later. But I just thought that was really interesting. And then apparently ricin, or the castor bean, is so smart that ricin has a lot of lysine in it, which apparently keeps it from getting tagged with ubiquitin. That's how the cell basically tags it for digestion, because it has a high lysine content, and I guess it's resistant to that. So it tends to sit around in the cell for a long time because it doesn't get chewed up by proteasomes. So really interesting, a classic poison, one a lot of people know about, gets used in a lot of ways. Fortunately, all the cases I've ever dealt with just have led to diarrhea, but not good diarrhea, very bloody, painful, but that's what we get. Oh, and then of course there's the rosary pea. We talk a lot about castor bean, ricinus communis, but there's also the rosary pea, which contains abrin, and it's another toxalbumin that will do the same thing. And for everyone listening, recently I looked that up. That is why that happens to be at the forefront of my mind. It's not knowledge that I carry at all times in my brain. Although now maybe I will. I don't know. Super fun. And that was a big tirade. Any other comments on ricin?
No, that was really cool, and I didn't know that that kind of granularity of the biochem. I obviously how it interacts with ribosomes, but to that degree and that kind of preserved motif, that was really cool to hear about.
Yeah, isn't that neat?
Yeah.
All right, you got one for me?
Yeah. This one, it's written in a way that I'm gonna kind of paraphrase it a little bit rather than read it directly from the case report, just because I think it'll be a little difficult if I just read it off the page. So this is a case of a 19-year-old who was exercising, let's say, questionable judgment in college with friends, and they were challenging each other to do a certain activity that would be medically dangerous. And so the patient in question performed this activity, and then within a couple of hours became unresponsive, was brought to the emergency department, where he was found to be in a comatose state, completely unresponsive, with seizure-like activity. And this was now 2 hours after this activity. The ER team was aware of what occurred, and so they started resuscitation. Now, I don't think I've given you enough to make a diagnosis, but maybe you could talk about some initial thoughts, and then I'll give you some more information.
Well, when I think of 19-year-olds challenging each other, two things come to mind: putting Tide Pods on pizza, which I guess was the thing, as well as the Benadryl challenge, trying to take as much Benadryl as you can. 2 hours. Yeah, if you take a lot, I mean, Benadryl slows your GI system, so you can have protracted symptoms. But if you take enough, it's going to absorb. pretty fast as well. Other things I'm thinking, it doesn't sound like the ice bucket challenge to me. I don't think we're there. I'm thinking, obviously, a 19-year-old just alcohol, challenging someone to drink as much alcohol as they could in a 30-second period, but or a 30-minute period. I wouldn't expect them to be seizing from that unless they somehow induce like a volume related hyponatremia, but I really doubt it. Like, is it a physical challenge?
It's an ingestion challenge, and I
Okay.
think everything you're saying is fantastic because we're thinking about how to tie in this clinical medical presentation with what's going on in the world and
The
what
social history.
the
This
social
has got to
history.
be the NyQuil chicken challenge. They cook the
Yeah.
chicken in NyQuil.
I'm so glad that I never had a case of that really happening personally. I don't know any toxicologists who have. I hope it never did. Maybe just to bring your listeners up, I think many may be familiar, but recently there was a large press release warning the public not to boil chicken in NyQuil and then eat it. Um, and I think a lot of us who practice clinically started just talking with each other and saying, have you seen this? I mean, has this occurred? Um, I have not had a case. I don't know
No.
anyone who's had a case.
So I saw another news article about the FDA warning about the NyQuil chicken challenge. It was basically like FDA's warning about the NyQuil chicken challenge alerts basically everyone about the NyQuil chicken
Yeah.
challenge that it even exists. So it was kind of like a funny equipoise. Like, did that help or hurt in this scenario? Because now more people
Yeah.
know about it. I don't, but people, it's I don't know if anyone really did it except that one video, but
Mhm.
certainly something to be worried about because I continue to be astounded by the challenges that go on. But okay, so I
It's a
guess
cool
if I was
practice
gonna
for
peg
chicken.
on something here, I'd probably go with Benadryl. Although it almost sounds Tessalon Pearly, depending on how quickly they dropped, but unresponsive, seizing, uh, 2 hours after. But anyways, any more info I can glean here? Labs, vitals, anything?
Yeah, let me give you some more information. And I think these are all great thoughts. And as I mentioned, I don't think there's enough here to make a diagnosis without a history. But let me tell you some of the labs. So there's one particular lab which really kind of cinches it, and that's that the patient's sodium concentration peaked at 196 millimoles per liter.
Mm. Were they recently at a Chinese food restaurant?
I believe so.
Okay. This is a classic tox case that I look at all the time just because it's so fascinating. I'm gonna bet. Well, all right. So it was a sodium related seizure. I'm gonna take that as a win. Uh, this is probably someone who drank a liter of soy sauce, or maybe it was a gallon. I don't actually
Ding,
know,
ding,
but
ding. Yeah, you got it. It's a
yeah,
soy sauce.
yeah.
So unfortunately, this patient, got really sick, but fortunately they survived and did well. And we'll talk maybe in a bit about how the team saved them. Usually, if someone is, unfortunately, people do drink, large quantities of soy sauce in these kind of challenges to kind of impress friends and be goofy. And if they absorb it, yeah, it can be really dangerous and life-threatening. Fortunately, what usually happens is immediate vomiting. And if you're willing to go down a very unpleasant YouTube rabbit hole, there are videos of people attempting the soy sauce challenge and then immediately vomiting large quantities of soy sauce. Dangerous and disgusting, but the vomiting is really protective in these cases. The issue becomes when the person does not vomit and they absorb all the sodium chloride. So what the team did in this case was essentially resuscitate the patient very rapidly with 6 liters of free water, presumably D5.
Wow.
And that would be in an attempt to essentially dilute that acute hypernatremia back into the normal or near normal range. And this patient did well. They woke up and they had no neurological sequelae.
That's amazing. Oh, terrifying.
Yeah.
Yeah, just don't drink a gallon of anything. There's so many gallon challenges. Gallon of water that's
Yeah.
going to cause hyponatremia. There's deaths from drinking too much water too fast. Gallon of milk is a real challenge. I know of people from school growing up who did that. I think that's a little more protective because you got proteins and fats in there to slow down absorption, and you just can't drink as much. But
Yeah.
yeah, and as a rule of thumb, a gallon of anything is rapidly poor, not a good
Space it
idea.
out. Space it out.
Space it out.
Safer that way. Yeah.
I'd say this, and yet I, as a youth, was once challenged to drink a 20-ounce glass of maple syrup,
Oof.
and I did not finish it. but not even for a moment did I think, could this be negatively impactful?
Yeah.
So we don't all make the best decisions. Really great. All right. You want to do another one? I have maybe one more fun one.
Sure. Yeah. I'd love to.
All right. So I just found when I was reading this one, I was like, this is just so interesting. So, okay. A 22-year-old professional gardener was brought to the hospital for detoxification from chronic cannabis use. The patient stayed in the hospital for 3 weeks until going to a different hospital. Not that important. On arrival to the new hospital, the patient announced his intention to commit suicide using poisonous plants. The following days, the patient was allowed into the hospital garden. Not sure that was the best move given what they had announced. Nurses entering his room noted plant material strewn about. The plant material looked similar to pine needles. They were flat green needles with seed cones, and some of the seed cones had berries around them, I guess, but it's not a great description. I could give you a picture if you want. You want a picture?
I think I know this one.
Okay, all right.
I think I know this one. So kind of taking a step back, a differential diagnosis of something a plant that could kill someone that might be decorative, that might be just casually planted in a hospital garden. So things I'm thinking about would include potentially rhododendron. This is something that can have toxin, which is a sodium channel opener. Very beautiful. Problem with it is these are thick, waxy leaves. It's really not functionally possible to eat enough of that to get thick. There's just these hard, tough leaves. It's just kind of not going to happen. Foxglove classic, gorgeous, beautiful flowers. They might be available, but I think a lot of people recognize those as toxic. In the autumn crocuses will be just kind of around. Those contain colchicine, so that's something that could cause toxicity. But I think what this patient likely took was yew, and that contains
Me?
taxanes. Yew, yeah, exactly, yeah, and that's something that it's a decorative bush. It's kind of it looks like a conifer. The leaves, they look like pine needles, and it contains these toxins that are sodium and calcium channel closers, and they can cause cardiac dysrhythmias and death. So that would be my thought.
All right, let's go through the final course and I'll let you nail down. So later that evening, after finding these flat green leaf needles and seed cones, the patient endorsed nausea and abdominal pain. And then a few hours later, a rapid response was called for bradycardia and hypotension. A bedside echo showed, severely depressed cardiogenic shock, depressed ejection fraction. He had shortness of breath. They were beginning resuscitation when he progressed to a wide QRS rhythm and lost pulses. And despite defibrillation, ACLS, and lidocaine and epi, ROSC was unable to be achieved. So, final answer?
It sure sounds like Taxus.
That is correct. The yew. I'm glad my description was enough to describe what it sounded like, what it looked like. Yeah. It's always tough. But yeah, the yew tree, really a fascinating plant. And what I find so interesting about it, so the yew tree, the Pacific yew, is actually where we get paclitaxel, the chemotherapy from, which a lot of people would associate with hematologic toxicities. It's a cell cycle specific inhibitor of cell replication. So most people, when you think of yew, if you happen to know that tidbit, you're like, oh yeah, this is probably a heme toxin. But no, you die long before that could occur. So taxane A and B, just like you said, calcium and sodium channel blockers, they can cause bradycardia, cardiogenic shock, wide complex QRSs, and decreased cardiac contractility. And that was just an interesting case. I was like, that was one of the forensic ones where they have a very brief description of what happens. And then they're like, and then we detected taxane in the blood, which they did. But it's a very interesting and scary toxin. We've had a couple of cases over the years, but great job on those. That was fun. Okay, so now we're going to move on to our next questions, which are toxicologists versus the internet. These are questions sourced from reddit.com/r/askdrugs. And there's a lot of interesting questions on here, and many of them have good forays into discussing some toxicology concepts. So we're going to do our best to answer some of these, looking at it through the lens of toxicology and kind of what we would think about if this was a patient maybe presented to the ED, or how these things can interact with people out in the world. So did you want to kick off? I guess I just asked the last case. Do you want to ask a question? I'll do my best to muse about it.
Sure, yeah. And this is a question that I found on Ask Drugs, and it's loosely inspired by the conversation that you and Emily had on your most recent episode about the meth bong water. It's not directly related, but there's a biochem tie-in here. So let me read it to you. I have a jar of isopropyl alcohol that's been through an extraction process. I just have to finish it off by evaporating the alcohol, but I wanted to know if it was possible to add any more THC into it before the evap, like keef, buds, etc. And so this individual seems to be asking for advice about the home processing and purification of THC.
Interesting. Now, I guess I don't know what they did, but yeah, this is sort of a question about solvents. There's some fun physical chemistry to it, right? So isopropyl alcohol is it's 3 carbons with a single hydroxyl group on it. So I guess I don't actually know too much about its aqueous versus lipid solubility. I would think the hydroxyl group is going to add some polarity to it, but it's probably maybe a little bit more because of the 3 carbons, a lipophilic solvent. And I really don't know. I know you can use it to dissolve natural, if it's lipophilic, that's where you get uncharged compounds. So those are the free base compounds that we've talked about before. So obviously, I doubt it's the most lipophilic. Let's take the example of a phospholipid bilayer, which is the fat part of your cell, the cell membrane, right? The cell membrane has a phosphate group in the front, which contains a phosphorus and a bunch of hydroxyls. And those hydroxyls all carry some polarity with them. And polar molecules like to interact with other polar molecules. Negatives like to interact with positives. So things like water, where you have a big electron-hungry oxygen stealing electrons from hydrogen and becoming very negative, water is going to interact with positively charged things very well. So this is why we consider water a really great solvent for charged molecules, right? But if you have an uncharged molecule, it doesn't want to interact with a lot of charged things. And that is better off in something where there's a nice equal electron distribution, things like long carbon chains, which are lipophilic. And that lipophilic, like long carbon chains, like the non-polar side of your phospholipid bilayer, which is the lipid layer, right? So fats are solvents that can dissolve fats and non-charged things. And water or other polar solvents, which I actually think isopropyl would be a little polar, given the hydroxyl head, are going to dissolve more charged solvents. This is really taking me back to pharmacies. In this case, he's got isopropyl alcohol. He's probably going to evaporate that all away. You can smell isopropyl alcohol when you walk into a room because it's so volatile, it'll evaporate very quickly. Your solvent will evaporate, and then you're left with just the solid of whatever you dissolved in that solution. And now he's trying to be left with large amounts of THC that is kind of, I guess, I don't know if it's crystallized or the solid form there. Or if you're like one of our guests of the show, you would be evaporating water to be left with lidocaine crystals at the end. So this definitely ties in. I don't have really a great answer for this guy, but isopropyl is, I guess it's easy to evaporate. I don't know if it's lipophilic enough to grab THC, which is a super lipophilic molecule. I mean, tons of heterocyclic carbon groups. That tends to add a lot of lipophilicity. But I don't know. All right, what do you think? I just rambled about that. I'm not sure.
No, I think those are kind of amazing thoughts, and get to kind of what is the attempt here is to essentially extract and purify this THC, and I think you explained the organic chemistry of it very well. Essentially you dissolve it in this solvent and evaporate off the solvent, leaving a more purified THC concentrate. And what I think can potentially get people into trouble is, one, with an aqueous solution that can't explode, but something like isopropanol probably won't, but could. So if someone were, say, impatient and wanted this isopropanol to evaporate more quickly, I'm not recommending this, but they could heat it. And what happens when you heat an organic solvent in an uncontrolled situation, like your stovetop, a stray spark can ignite all that isopropyl vapor and lead to a fire or an explosion. And something similar that we see in various kind of, let's call them labs across the country, is, I want to even say, the successor to the meth lab explosion, which is the butane hash oil explosion. Because in an attempt to purify THC, some people will use butane, which is lighter fluid, right? That's gas under pressure becomes a liquid, and it's a good solvent for THC. And when you release the pressure, it evaporates off, leaving purified THC. And if you have large quantities of butane in a less than perfect, in storage environment and less than perfect laboratory conditions, that can be really dangerous. And it's essentially an apartment-sized bomb. And so there have been these just explosive, apartments and hotel rooms across the country related to that.
That is just wild. I mean, it makes perfect sense.
The kind of the lower tech and probably safer concept here is really just pot brownies. So if anyone who's attempted to make pot brownies knows, if you heat the cannabis leaf in water, it doesn't extract THC at all. It has to be extracted into some kind of organic solvent, so something that you can eat. So typically it's going to be butter or oil, and so that's not going to end up being evaporated. It'll just be an ingredient in those brownies. But it's kind of, from an organic chem point of view, it's kind of the same idea.
Right. Absolutely. Question for you.
Yeah.
What weighs more, a pound of water or a pound of butane?
Great question. On this planet, they're the same.
Well, actually, you'd think that, but butane is lighter fluid.
Oh, that was good. That was good.
I
good.
read that the other day, and I just laughed so much. I was like, I can't not say that right now. This is the perfect time.
That's amazing.
But yes. Okay, wonderful. On to another question. So how about, there were so many good ones. There was a great one about, can paracetamol get you high? I don't think we have time to dive into it, but because they Googled and they found that acetaminophen reduces negative emotions. So they were extrapolating that into, can you take that to have positive emotions? But the whole acetaminophen and emotional aspect was really interesting, because I've actually read some studies on this. And it has to do with the fact that humans are such social animals, right? We feel physical pain, but we also feel kind of emotional pain of like rejection, right? That's a negative emotion, just like pain can be a negative feeling. Or so they're both negative feelings. And there's actually some pretty interesting studies that acetaminophen not only reduces nociceptive pain or physical pain, but it also reduces the severity of negative feelings related in a scenario where someone is experimentally rejected. So I think that's kind of cool. It's I guess everything we experience winds up, it's all experienced through the brain for the most part. So not that surprising that it can have effects on non-physical things. I can't remember where I read that. I think it was a book called Moral Animal about evolutionary biology by Robert Wright. Okay, well here's one. I don't know. This isn't even a great question, but yeah. So this is a question about clonidine. They say clonidine questions, low heart rate while sleeping. I was prescribed clonidine for general anxiety disorder and panic attacks and have been taking a quarter of a 0.1 milligram tablet twice a day. I'd like to move up to half of one because they're really hard to cut into quarters, but I feel it might be difficult because I've been having my heart rate dip down into the 52 beats per minute while I'm sleeping, which I know isn't dangerous, but my heart rate normally only gets down to 55 to 58. And I'm concerned that moving up to the increased dose will drop my heart rate even lower. And I would like to wake up tomorrow. So they're concerned about clonidine. What do you think? Can clonidine cause bradycardia? Maybe we can talk about that.
Sure. That's an interesting question. And I think any concern about adverse drug effect should definitely be brought up with the prescriber or the pharmacist, just to answer all these questions, just to make sure that the source of information is high quality.
Right. This is not medical advice.
Yeah.
To clarify, this is not even related to this person's specific question. Right.
Yeah. I absolutely agree. This is kind of a general kind of rant on the topic of clonidine and bradycardia. So I guess kind of just backing up, what does clonidine do, and then what do we expect it to do at these doses, and the basis of this question. So clonidine is an alpha-2 adrenergic receptor agonist. These receptors are predominantly in the brain and control the outflow of the sympathetic nervous system tone. And so the intended effect of clonidine is to decrease heart rate, decrease blood pressure, and potentially, in certain cases, quell a little bit of anxiety. And we see drugs with the same mechanism of action actually used as anesthetic. So, for example, dexmedetomidine, which is an ICU sedation drug, and it can be used also as a sedative for dogs. My friend's dog takes it when there are fireworks out. Shout out to Violet, the dog.
Is it oral?
It's oral, yeah. Well, it's buccal, so they'll put it on, yeah, the inside of the dog's mouth. And also what we're seeing more recently across the U.S. Of xylazine exposure. So these are all drugs in the same family, same mechanism of action. Now, kind of coming back to the dose, and Ryan, as a clinical pharmacist, I think you can probably talk about this more precisely than I can, but a quarter of a 0.1 milligram tablet is a very, very low dose. And not to say that it would have no effect, but decreasing the heart rate from 55 to 52 beats per minute at night sounds about what I might expect. That's, for context, not a huge change. So
yeah,
kind of where I land on it.
It's interesting. Maybe they could sleep with an Apple Watch on and have it alert them when they drop low. I chose this question. Clonidine is such an interesting. All these alpha-2 agonists. It's a really fascinating drug. I always love teaching learners how it's like one of the big opioid mimics. Now it's in opioids, so it doesn't really matter. But yeah, it can also cause meiosis, prodypnea, sedation, all that kind of stuff. So, okay, here's the real reason I asked this question. I'm just curious if you've had a similar experience. Maybe this is just me. We get these clonidine overdoses. One of the things we like to see before we feel more comfortable about discharging somebody who's overdosed is that their vital signs have returned to normal. Because after an acute ingestion, once the effects are gone, everything should resolve unless there's been some kind of a permanent injury. But largely your vital signs should return to normal. I get these clonidine ingestions. It's usually in young kids, not young, but teenage, with like athletic bradycardia at baseline. I swear they end up with heart rates in the 30s while they're sleeping after a clonidine ingestion. And obviously they're asymptomatic, so it's not that big of a deal, but it just causes this conundrum. How long do you let someone sleep in a hospital because their heart rate's 30 when they're totally asymptomatic? But then at the same time, it's like, well, I don't know if I want to send you home if you're dipping to the 30s. It just, I don't, have you any similar experience? I feel sometimes I need to be there for other reasons, anyways, but I just tend to see prolonged bradycardia with this, usually sleep related, but I don't, anything like that on your side?
Not that I've noted, to be honest. With, I
Maybe it
guess,
is just
yeah.
me. I don't know.
No, I'm sure it's something that other people have observed too. I guess from a clinical standpoint, it's a cop out answer, but I guess I would say you won't be discharging them in the middle of the night anyway.
That's
So
true.
you'll go by their waking vitals, presumably.
That's true. Get them up, walk them around, have them jog
Yeah,
down the hallway.
yeah. Give them a cup of coffee.
Yeah, exactly. But yeah, bradycardia, very common with clonidine. So not so much of a surprise that he's having that kind of a side effect. If you wanted to do another question, we could.
Let me see. I do. Let me see if it's a good one. So this is a Reddit user who's asking a question, and it's not quite phrased as a question, but the request is tips on things you can do to speed up the process of getting normal sized pupils after opiates. And this Reddit user is saying that they were invited to family members' house and they're on buprenorphine and they don't want to have small pupils because the family may detect that they're under the influence of opioids.
Well, very interesting. So this gets into a good discussion about the effectors of the pupillary size. And obviously, there's a lot of things that can do that. You have two things that can cause miotic pupils, opioids and cholinergics, which are both going to narrow the pupil size. And then you have some things that can cause mydriatic pupils, which would be anticholinergics, kind of makes sense, and then stimulants or sympathomimetics. I kind of think of it like if you're running from a bear, you need like those wide pupils so you can see every possible, obstacle in front of you. Um, but it is interesting because they work at different sites. The sympathomimetics use alpha adrenergic agonism to widen pupils. The cholinergics use acetylcholine to induce smooth muscle contraction that leads to narrowing of the pupil. But then opioids actually work at a higher up center, something called I'm just going to call it the EW nucleus. I think it's the Unit Westphal. That's wrong, but it's the
Integer
EW.
Westfall? Yeah.
Unit, yeah, there we go, the Uniter Westphal. And they are a higher up input. So I guess it's a question, if I have opioids on board, can I use a lower input? Like, can I just add some atropine eye drops to my eyes and widen the pupils? Which actually probably would work, is my guess, because, the EW nucleus is kind of a taking off the brakes effect. When you use opioids, they inhibit the EW nucleus. There's a great post on this by Dr. Justin Corcoran called Tox Pupils, written with that goes over this well. But the answer is yes. Polypharmacy can change your pupillary size. I think if you're on buprenorphine for substance use disorder, I'm really sorry you have to hide that. You're making good harm reduction decisions, so don't be dissuaded. But I don't know. Maybe you could clarify the muck I just made of this topic, Dr. Blumenberg.
No, I think you kind of hit the nail on the head there. We have all these different mechanisms, and so from just a biomedical standpoint, yeah, you can make the pupils larger with something like an anticholinergic. Atropine being classic, that can enlarge the pupils in someone who has no brainstem reflexes at all. And then another one that we see kind of in the emergency department more often is the multiple variations on what's usually called a speedball. So someone takes a stimulant and an opioid at the same time, or a stimulant and a sedative at the same time. The classic speedball being heroin and cocaine. So that could be someone who potentially would have some degree of opioid toxicity, but might have some peripheral signs of sympathetic activation like mydriasis or diaphoresis, sweating. There are certain substances out there that might, in a single molecule, have both sympathomimetic and sedating qualities. So not opioid, but sedating. One that I think of is phenibut, which is, if you look at the chemical structure of it, it has a motif that looks like GHB. And so it has a very kind of CNS depressant quality to it, but it also is a phenethylamine. And so it also has some stimulating properties. So yes, the short answer is you can increase the pupil size, but I just want to echo, Ryan, what you said, which is congratulations on making a really good life decision in the harm reduction standpoint. And it is unfortunate that has to be hidden.
Good old phenibut. I got so much flack from Dr. Emily Kiernan for that episode I made where I called it phenibut over and over. I understand, yeah, it's based off of the gamma aminobutyric acid, but phenibut just rolls off the tongue. There's a lot of these in the world, right? You got barbiturates, barbiturate, bupropion. There's so many different. I know the right way. I know why you say it, but it just.
One of the most intelligent clinicians I've ever worked with pronounced ibuprofen ibuprofen. So, the content, the meaning of what he said was carried over. There were no meta errors related to it.
It's a group effort. We all, we're all
humans. We're all doing our best.
Well, that was a wonderful explanation. And anytime we can bring phenibut up, that's really great. And I wanted to run back that case that I talked about, the ricin case.
Mm-hmm.
There was something that if I was being read that case, I would have gotten it completely wrong, and I would have guessed the exact wrong thing. And I know what I would have guessed. It would have been, so as a patient, they injected something in their bicep and developed twitching. And that's probably what I would have anchored on. And then they have kind of multi-system meh. It wasn't even that bad of organ failure. It was like a little liver sweat and creatinine bumped a couple days later. But twitching and injection of non-pharmaceutical substances makes me think, okay, it could be like strychnine, but I doubt it's that. Wasping? I don't know if you've seen this. This is where people actually inject pyrethroid insecticides because they have stimulant-like effects. And it leads to some twitching. And I've recently, my residents, we were doing kind of a little form of the Stump the Tox that we do, and somebody got me on wasping recently because it's very non-specific. The only thing you can pick up on is I'm injecting a bunch of insecticide. But that would be another thing on the differential, I think, is if it weren't for the 400 bean thing, that kind of sounds like wasping to me. Have you heard of wasping? It was
no, I haven't. I've never heard of that, but it's hard to be surprised at this point by just what people do.
Always new things coming up, so just got to keep an open mind, I guess. Well, this has been absolutely wonderful. I really appreciate you coming on the show, sharing your sage tox wisdom and all the cool talks and educational things that you're involved in. I guess any final words you'd like to share? Any last thoughts about talks or anything we talked about?
No, I just, it's so fun going through these cases and kind of picking them apart, both up and down from the clinical to the biochem and back. So thank you for having me.
Thrilled you joined the show. It's been really, really wonderful. Thanks for sharing your Tox Museum with us and all of your other really impressive toxicology initiatives. So everyone should check out Dr. Blumenberg's podcast, Toxic History. Check out his med simulator as well as Tox Runner to get yourself up to speed on various toxicology topics. And we appreciate you being on.
Thanks, Ryan.
That'll wrap it up for today's show. I hope you had fun listening to myself and Dr. Blumenberg opine about toxicology subjects. If you like what you're listening to, give us a follow wherever you listen to podcasts. And please leave us a review. It helps us reach other listeners who are interested in learning about toxicology. You can follow the show on social media, on Twitter at Lab Poison, myself at EMPoisonPharmD. We have a Facebook, The Poison Lab, and an Instagram, Tox_talk. As always, you can go to our website, www.thepoisonlab.com, for all free medical games, resources, and podcast episodes. Be sure to check out Dr. Blumenberg's initiatives as well: ToxRunner, Toxic History, and the MedSim Studio. Don't forget, you can reach out to the show anytime at toxtalk1@gmail.com. That's TOXTALK1@gmail.com. We'll be posting teasers for upcoming episodes and maybe asking for listener guesses. So send your guesses in if you want to take part in the next episodes, or reach out if you have any suggestions about the show. That'll do it for today. Thanks for listening, and I hope we can see you next time. Hey Toxo, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. The opinions expressed on this show do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Don't forget to give it a share with your nerdy friends. Cheerio, mates. See you next time.